we've got this idea of the anterior and posterior oblique slings. So closest to you, posterior oblique sling, which is fairly well described now and understood. So you've got the glute on one side, passing through the thoracolumbar fascia into the lat on the other side. And I'm trying to remember the exact anatomy of it, but they're on the same layer of fascia. Okay, so the thoracolumbar fascia has multiple different layers and lamina. If I remember, it's the superficial lamina of the posterior layer of the thoracolumbar fascia that those two muscles are on. Yep. So when one contracts, it pulls into the other one. And this is, again, it's not particularly new. I think way back in the early 1900s, there was descriptions of this. And it's also known as the smart spring of Margaria. But the idea is that with each step you take, you get a certain amount of elastic energy stored, and then you get the recoil on the next step.
This bloke's got a hell of a scowl going on, carrying that deer, hasn't he? Not happy at all.
That's it. He must have had a tough day. But so then the one that's not so well known is the anterior oblique sling. Yeah. And that ties in a bit more with the middle cross syndrome, although they both work synergistically, as you can imagine, because as one arm goes forwards, the opposite leg goes forwards. And so what that means is that relatively the other arm and leg are going backwards. So that's putting a stretch through that anterior oblique sling. And then you get the recoil, and then you get the stretch in the other anterior oblique sling. So this is a kind of mechanism for optimizing efficiency as you walk through a field of gravity. But if you are right-handed, let's say, or in fact, let's use this one, because this is showing from the right leg to the left arm. So if we said this person's left-handed, well, they're likely to facilitate the sling from the right leg up into the left arm, because that's what they're going to use mainly to throw things, to carry things, and so on. So if he was a tennis player and he's a left-handed tennis player, well, that's the sling that's going to be used the most, and therefore it's likely to become facilitated, and relatively you're going to get inhibition or deconditioning or weakness of the opposite sling. That then creates an asymmetry, and this is where it kind of links back in for the manual therapists out there that look at things like pelvic torsions. Well, if you've got an asymmetry in those slings, it's going to create a torsion in the pelvis. Okay. Yeah. So we can certainly go in and mobilize and manipulate the pelvis, but if we don't address the underlying musculature that's controlling the pelvic movements, then it's going to keep going back.
25% of your brain's made of cholesterol, dry weight. It's essential for the production of synapses. It's just an essential neuronal function, and you knock that down. What's going to happen in your brain? Well, it's not going to be good, is it?
Yeah.
And I believe there is a huge amount of not done research out there demonstrating, and muscle pains and joints. You'll get this such a lot. Muscle pain, 40% of people. So if you're talking about this group, why is it important? Someone's getting muscle pain and joint pain and difficulty gripping, and you say, "Are you on a statin?" Well, let's see what happens if you stop it for a bit.
Again, I asked you this before. I mean, where do we stand as physical therapists in saying to a patient, "Well, try stopping your statin"?
Well, I'm not brave enough to do that. Yeah, of course.
It's outside our scope of practice.
It is outside your scope of practice, but I think you can suggest. I've seen a lot of people like this. Maybe you want to go and speak to your GP.
Yeah. And I say to a lot of them, you might want to read one of these books.
Well, yeah. I mean, it's ridiculous, isn't it? You should be looking at causes of things. Here's a potential cause of a thing, and you're not allowed to discuss it. I mean,
so imagine we've got an acute low back. Okay, now the bridge exercise generally is done, if you just bring your legs up, with the feet fairly close together. Yeah, in fact, in a Pilates exercise. And so if you just lift your back really, and what that does in a traditional pose, which is actually quite hard to do when someone's back's either very stiff, and yours is somewhat, and pop it down again slowly. Right. So what we see a level of excursion. Now, in someone very acute, they probably wouldn't get 2 centimeters off the ground because it would just be too painful to do. And in someone very stiff, they'd also find they wouldn't get to that sort of diagonal between the knee and the shoulder. Okay. So even with you, that was a little bit tough at a point. Yeah. Now, what we want to do is make exercise easy and effective. So communicating that with the patient is really important, because nobody wants to do painful exercise. even if it's helpful. So what we're going to do is just, for the time being, just pop your hands just up, just on your front. That's fine. Okay. So the way I'm going to do it that's quite different is to actually put the feet, in this instance, and you'll find that quite difficult because your adductors are quite tight and the hip girdles are tight. Get them quite wide, okay, to start with. Now that's quite different than the original start position we had. And if you just put your hands down now, just flat down, what we're looking to do is to bring your heels towards your fingertips. So that sort of distance back. Now, and just bring your big toe. What happens, the further back you go, the more rotation starts to happen because of the glutes. So you want to just turn the feet in so your feet are parallel, okay, which is quite hard for you to do. Put strain actually in lots of areas, and we can't see from that side, but puts lots of areas onto these peronei as well. Okay, so now we want you to do that same bridge, but differently. I want you to actually use the thigh muscles and your calf muscles to do that bridge, not your back muscles. Okay, so pushing up. Okay, and now you should find that's a little bit easier to do, less effort, because now the legs are doing the work and the back, just drop down slowly, is actually basically doing less work.
But it is still working.
But it's still working, and your pelvis needs to stay quite free. Now, most of the time with so-called core exercises, which we're not doing here and we don't want to do, is that the core gets so engaged with the lumbar spine that you're peeling the back off the ground. And that is an exercise a lot of people do for core strength. But the trouble is you're developing tension as well as anything else.
Now, I will tell you just a very brief anecdote about the acceptance of myogenic thoracic outlet syndrome. I was at the first Aspen conference on the medical problems of musicians and dancers. This is many years ago. And they had the folks from the University of Colorado, both the neurologist and the thoracic surgeon there, talking about thoracic outlet syndrome. And they made the point that this was rare and that the most common problem was disputed, which is what I would call myogenic. And I got up and I made the comment that much of what we see is related to muscle and not nerve compression, to which all of the ballerinas present at the conference, and there were many, applauded. But the neurosurgeons and the thoracic surgeon looked at me and said, A, you're crazy, and B, this is a highly controversial, disputed topic. So the neurologist and the thoracic surgeons went out to lunch with each other, and I went out to lunch with the ballerinas.
Lawrence wants to know whether this could be a factor affecting scoliosis, and I'm assuming he's talking about middle cross syndrome here.
Yeah, absolutely. Absolutely, yeah. Because, I mean, we've talked about this before. One of the models I like to use to understand human function is Punjabi's model, which is this, neural, active, passive triad. And so, of course, you've got the active component of the muscles, which we were talking about, acting on the joints and the bones, which is the passive. So that's the scoliosis is happening over here. But what's controlling the muscles is the nervous system, and so we absolutely, if we can work on addressing the nervous system factors and addressing the imbalances in the sling systems, then we can affect the position of the spine. Now, obviously, the thing with scoliosis is a bit like with hallux valgus. You can correct a hallux valgus to some degree, but it depends on how dedicated the patient is, because you're fighting a battle with gravity again. Gravity is trying to compound the scoliosis, it's trying to compound the hallux valgus. So you've got to be dedicated. You've got to create an equal and opposite force to that, which might include orthotics, but certainly a lot of corrective exercises, the right sort of stretches, maybe braces for the spine or braces for the foot, orthotics for the foot. But the point being that it would have to be a big priority for you if you wanted to achieve that. But it is achievable because there's, we know about Wolff's law, but that's essentially the SAID principle, which is specific adaptation to imposed demands, which means that the body will always adapt to the demands imposed upon it whilst it's alive.
I got you started on a red herring there, didn't I? Because I cheekily said, yes, it must be cholesterol. Well, I knew very well you were going to tell me it wasn't. So what is causing the damage to the endothelium?
The damage is, an endothelial cell, say it's, say it's this size, and it's quite thin, it's like a cell. Now, obviously the blood's flowing past them all the time. and quite rapidly. Now, all endothelial cells have got a thing attached to them called glycocalyx. Again, you ask 100 doctors, no one has any idea this exists.
This is the slippery stuff on fish.
This is the slippery stuff on fish. You try and pick up a fish, well, not all fish, sharks don't do this, but a fish you catch, normally a small fish, you grab hold of it straight out your finger. Why? Because it's covered in glycocalyx, which is really slippery, doesn't let anything stick to it. And it also acts as a barrier to bacteria and viruses getting into fish. The glycocalyx is very important for not letting infections in. Why? If you get too many fish together, like salmon farms, they bash into each other, they knock the glycocalyx off, they get horrible infections. So the glycocalyx is an anti-infective, anti-clotting. It's got about 20 substances in it that are anticoagulant. Yeah. It allows the blood to flow through really smoothly and fast, and it doesn't allow anything to clot, to stick. Now, if you damage the glycocalyx, then basically the endothelial cells are at risk. Things start to can either directly attack them or bash against them or do damage to them. And once you've damaged endothelial cells sufficiently that they break off, you expose the underlying blood vessel wall. And when you do that, that's a red alert. We think, a big blood vessel getting damaged, the body says, clot now, otherwise you're going to bleed to death.
The pain maps that you put up there are from the software, from the app, which is Trigger Points 3D, which we would love you to have a look at. But one of the things about them is that often these trigger points wrap around the body in 3 dimensions, especially the scalenes. You can have referred pain in the posterior, periscapular, anterior. So one of the great advantages with the software is that you're able to sort of look in 3D and turn the body around and look at where those maps are.
Yeah, every time we do a show with you, I do recommend this to people because it's a superb app, and it's a wonderful, wonderful visualization of how these things happen, and very, very user friendly, I think. And I'll point out to everybody, I don't get any commission on the use of the app either, so that's a genuine opinion.
If you want to, and this is something I do quite often as well, is to see, just let your head go into my hand, is to do the same exercise, get your heels apart just a little. Your heel, yeah, that's it, good. Right, so let's see you do that push breathing. And I'm gonna feel, just push, how much tension, and I saw it, his head rising off the pillow earlier, is coming into his neck muscles. And you can actually palpate suboccipitally. Yes. You can palpate into the neck and see where these tension lines are coming from his upper to lower body and his lower to his upper. So how that bounce goes between the two. Mm. And obviously translating heavy work into football, yeah, and you can feel that rising. You could even turn this into, he can do the exercise and I can actually treat his neck at the same time and actually release his upper neck. So functional active release, this starts to become why it is what it is, that we're using functional exercise, and it's very profound because the fascial tension that I'm getting through his scalenes and through his traps is massive, and he's kind of controlling it using his body movements.